Assalamu alaikum, the clinical day. First scenario, Mr. Adam Smith, 62 years old male, presented with worsening cough and fatigue. His vitals, blood pressure 130/80, pulse rate is 90, respiratory rate 24. His ECG showed ischemic changes. His past history, medical history, had heart attacks. Please sit with him, examine, and address his concerns. Dr. Muhi, are you ready? Sorry, Dr. Huda, you are
Yes,
ready?
Okay, yes.
Okay. I'll share the timer, then you can start right now. Here you go.
Hello, my name is Dr. Huda, one of the doctor in the clinic today. I'm talking to Mr. Adam.
yes, I am.
Mr. Adam, we are here today to discuss some issue related to your health condition. Is it okay with you?
Okay, doctor.
So before proceeding in further discussion with you, can you tell me more how much do you know about your health condition? I have letter from your GP stating that you have this cough and tiredness. Can you tell me more about that?
Actually, doctor, for about 3 to 4 years now, I have this cough. But recently, about 4 months back, I think it increased and become worsening with time.
Okay.
This cough and it gives some phlegm, and this phlegm sometimes it is bad odor and increase in amount.
Okay, so and at that years, did you know the reason for this cough? Did you given any diagnosis for the reason for it?
Actually, doctor, I have heart attack before, and my heart is weak.
Oh,
So I'm not sure if this is related to the heart problem.
right. And regarding your heart problem, are you on any medication?
Yes, I have this aspirin for because I have a stent in my coronary. I have aspirin and medication for the cholesterol and for blood pressure and for the weak muscle also.
Okay.
Uh,
So are you, yeah.
yes,
So are you compliant with this medication?
yes. And the heart doctor told me it is very important to be adherent to the blood thinning medication. So I usually adherent for this medication.
Okay, so you mean that you are on the regular follow-up and checkup for your heart problem in the in outpatient
Yes,
clinic, right?
yes, 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 doctor.
Yes. Okay. So I can understand this. The problem with the cough is increasing in the last few months, right?
Yes.
So previously you have these episodes of cough, right?
Episodes?
Yes, you have these cough problem with cough previously, right? Only increasing in the
It,
recent few months.
it is 3 years back or 4 years, but in the last 4 months, this cough I
Mhm.
cannot afford it. It is very much really.
Yes, and at that time, your cough is it dry or associated with a phlegm?
It has is a film since long time, but this was no problem for me. I'm
Mhm.
walking and going and coming to my work, no problem with some shortness of breathing. But recently, in these last 4 months, I cannot afford this. I cannot cope for my life. I
Mhm.
cannot go to my work because of repetitive cough and the phlegm, and I feel tired, weak all the
Yes, I can understand that. Okay, so the
time.
cough. Okay, so now the cough, the phlegm, which color? Is it green, yellowish?
Sometimes white, sometimes yellows,
Does it?
and also become bad odor also.
Okay, and does it associated with any blood?
I am not sure for this blood.
No blood. Okay. So,
No
okay.
blood, yes.
So, first I want to ask you, do you have any, you say do you have difficulty in breathing? Is this difficulty in breathing mainly on activities or even at rest?
It is present at rest and they become worsening with effort.
Yes. And, okay. And at night when you sleep, do you sleep on pillow, one pillow, two pillow, or no
Only
problem?
one below. Only one below.
Okay, only one. And okay, do you have any rising in your heart?
No.
Okay. Do you notice that this difficulty in breathing sometimes it's increased when you lying flat?
No.
Ah, okay. And when you bending forward, does it this increase this difficulty in breathing or relieve it?
I'm not leaning forward at all.
Yes.
I
Okay.
usually sitting or semi-sitting in the bed to be more comfortable.
Okay. So at night, sometimes do you just wake up suddenly, just gasping for air?
No, no, no.
No. Okay. Any leg swelling?
Any what?
Leg
Leg?
swelling? Leg, yes.
No, 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 no.
Right. Okay. Any chest pain?
Yes, I have chest pain. Yes,
Can you
you
tell
are
me
right.
more about? Can you tell me more about this chest pain? Where
This chest
the
pain, it is in the right side
and since when you have
and
this chest?
refer this to my right shoulder also.
Okay.
But it is not present all the time.
Okay. So it's an on and off. And since when you notice this chest pain?
About 1 month back or one
Okay.
and a half like this.
1 month back. Okay. Okay. Do you notice this chest pain sometimes even go, you say to your shoulder, sometimes going to your jaw or
No,
your back?
it may extend it. It may extend it to my
To your what? No.
arm, right arm,
Yeah, دكتور ممكن تشيك your connection
arm,
معي.
right upper limb,
Okay.
right upper limb. Yes,
Yes. And can you describe how this chest pain felt? It's more of a stabbing or heavy. How you describe it?
it is dull aching.
Okay. Okay. And if I just say to you from 1 to 10 and 10 the severity, how much you grade this pain?
3 from 10 like this.
Okay, I'm sorry about that. Do you use any medication to relieve this chest pain? Sometimes
Some
I
painkiller.
that you have heard the
Some
problem.
yes.
Yes.
Sometimes I use painkiller and it be okay.
Okay, so on painkiller you get some relief.
Yes, yes.
Can you mention the name of medication that we use that give you this relief?
Only paracetamol, doctor.
Okay. Okay. So
They could. Yes.
okay. Okay. So you told me that you have a problem with your heart previously, and did you know the reason for this heart problem and what happened exactly at that time?
Yes, I have a heart attack and I went to the cardiac center and they do for me catheter and they insert
Mm.
stent in my left coronary artery. And 2 years later, they do another angiography and they put another stent in the other artery, right coronary artery.
Okay, and the last one, since when? The last
1 year. That's 1 year back.
1 year back. Okay. Okay, so with this difficulty in breathing and cough, do you have any raising in body temperature?
No, no,
Any sweating?
no.
Okay. And do you have any runny nose?
Runny nose? No.
Yeah. Okay. Any recent illness?
Any?
recent illness, like flu-like illness?
No, no, no.
No. Okay. So I will ask you further. Do you have any okay, any blood come out from your back passages or any
No.
orifices in your body?
No.
No? Okay.
No.
Okay. And you mentioned that you don't have any episodes of coughing up blood.
No coughing of blood. Cough with phlegm, and the phlegm is white or yellowish
Right. Okay.
discoloration only.
Okay. And any one of your family having this flu-like illness recently? No. Right.
No, no.
Okay. So okay. So do you have any weight changes?
Any what?
Weight changes.
Yes, yes, doctor, you are right. I lost weight in these 4 months, about 4 kilogram.
Okay. 4. Over how long? 4 kilograms?
4 months.
Over 4 months, right? And do you try to lose this weight?
No, no, no. Because
Oh,
I am tired all the time, and I feel also my appetite become food.
become less. Okay. So right. Do you have any contact with someone with TB recently?
No,
Okay. Did you travel to any area recently or previously?
no,
No.
no, no,
Okay. I'm sorry to ask these questions, but do you have any use of any illicit drugs or using of any illegal drug through a needle?
no, 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 no.
Right. Okay. So okay. So do you have any surgery in the past other than this heart problem?
No, no surgery.
No surgery. Any medical condition other than this heart problem that you have a few years ago?
No, only heart problem and the weak muscle, heart muscle. And I receive medication, and I'm keep follow up with the cardiac center.
Okay. So I will ask you any disease run in your family?
No, my mother has diabetes only, and my father has hypertension.
Okay. Right. So do you have any high blood pressure? Do you check your blood pressure recently?
My blood pressure is acceptable as outside 130, and
Right.
I think this is controlled by the medication, because heart doctor prescribe for me medication to keep
Yes.
blood pressure within normal values because of weak muscle.
Okay. Any high blood sugar?
No,
Did you check your blood sugar recently?
they check it for me,
Mm.
and no raise of blood sugar.
So any sometimes you feel that you want to drink water more than usual or pass water work more than usual?
No, my water work is okay,
Right.
and my
Oh,
drinking water is okay.
okay.
But I wanted to tell you, doctor, every time I go to the heart doctor, he told me, please stop smoking because it is harmful to your heart like this.
For sure.
But I cannot stop smoking,
Are you
really.
continuous to smoke?
Yes, really, I cannot stop smoking because about 30 years now I'm smoking. How they wanted me to stop smoking in
Okay.
3 or 4 months.
Okay. And did you try to stop smoking?
I tried, but I failed.
Okay, I will try to help you if you like to, because it's essential to stop smoking, especially in your case. We'll try to refer you to smoking cessation clinic if you like. But any high blood cholesterol?
Okay. It is under control with heart doctor.
Okay, and any one of your family have high blood cholesterol in your family?
I am not sure for this, doctor.
Right. Okay. So, okay, did you drink alcohol?
No, no, no.
Right. Okay. So now, do you have any headache?
13 minutes, Victoria.
No.
Okay. Any headache? Any weakness or numbness anywhere in your body?
Yes, I feel weak in all my muscles, but mainly I cannot cope for my combing my hair, and I can not
Mm,
raise climbing stairs. I feel
right.
very weak. I cannot go to work like this.
Okay. So any a joint pain anywhere in your body?
I feel some discoloration in the back of my hand, and also my muscles of the hand become very weak and they become thin. I am not sure of what it is.
And do you notice it's more painful and decrease you see the bulk of the muscle is decreasing, right?
Yes,
So can you show me this discoloration?
yes, I have discoloration in the knuckles of my hand and also in my
Okay. Right. Okay. So do you have
eyelid.
okay? So do you have any hair falling?
No, no,
Any rash on your face that is um, that change with exposure to sunlight?
yes, there is rash but rash on it is fixed, not changed by sun
Right.
exposure.
Okay. Any mouth sore?
No,
Okay. So do you have any changing in your water work? Any frothy urine?
no,
Okay. Any puffiness around your eye?
no.
Okay. Right. So I now will try to examine you. First,
Yes, examine me. Yes.
yes. First, I will look to the patient general look. Is he look low body mass index or Kajecsic? And then
Yes,
yes,
he
mm,
looks Kajecsic, yes.
yes. Okay, and then I'll go to his chest, mainly to auscultate his chest, mainly basally. I'm looking for
His,
finding.
his, you want, yes, listen to my findings. There is diminished air entry, there is generalized wheeze, there is diminished air entries, tony dullness in the right basal of the lung, right lung. Um, he picture of COPD, okay?
Right. Okay. So then I will
There
check.
is also, there is bronchial breathing also in the upper lung field.
Okay, and then I will check the signs of pulmonary hypertension, right ventricular heave, elevated JVP,
No pulmonary hypertension. No pulmonary hypertension.
and then I will auscultate for any murmur,
No murmur.
right? And then I will go up to his eye, looking for any pallor or jaundice.
No pallor or jaundice. But when you are looking into the eye, you found that the right eyelid is partial ptosis.
Right. Okay. And then, all right. Then I will go to his mouth, looking for any, raise his tongue for any cyanosis, poor dentation, and any ulcers.
No, no,
No,
negative.
all right. Negative. And then I would examine his hand by asking to checking the proximal myopathy.
There is proximal myopathy bilaterally, yes.
Yes. And then I will go to his hand, asking to check his blood pressure and checking the pulse. Is it regular?
Pressure is like outside and the pulse is okay.
Okay, and then I will check this rash and ask him for any joint pain now. Any in
All
the
joint.
proximal, sorry,
Any what?
joint pain in the interphalangeal joint or the proximal interphalangeal joint. Any deformities?
No deformities. He said only, I feel weak on all my body, including the joints. Like this.
Okay, and then I will go to check his lower limb for pitting edema.
No edema.
No edema. Right. So, okay, Mr. Adam, do you have any history of like blood transfusion before?
No, no.
Okay, and regarding your medication, can you give me your medication list? And
The same as I told you,
yes,
81 milligram, Blavix,
okay.
or 75 milligram, Concord 2.5 milligram, Coversil 5 milligram, Cristor 40 milligram.
Right, and
This is my
you mentioned that you are complying with this medication. Any herbal medication?
no, doctor.
Okay, time left.
Do you want to
Okay.
examine anything else? Do you meeting anything else in examination?
I would check the carotid bruit,
No, carotid.
Sorry.
It's 20 minutes now, Dr. Huda.
No carotid bruit.
Okay. So time finished.
Okay, just answer the
Yes.
concern. Answer the concern.
Yes, and now can I ask you what's your concern?
Doctor, why I lose my weight? Why I have tiredness all the time like this? Why
Yes.
changes the character of my cough?
Yes, I
already all I have cough. Yes.
Yes, I highly appreciate your concern. So after taking history from you and examine you, most likely there's multiple reasons for the complaint that you have. One of the possibilities could be cancer, and we need to be to exclude it. So we will run some blood tests and some imaging to make sure what will happen further.
Cancer? Cancer where, doctor?
Maybe in your chest tube and your lung.
Oh my God.
Yes.
So what you will do now for me?
We will admit you for a short while just to run some blood tests and some imaging, and we will see what will happen further.
Okay, doctor. Thank you, doctor. Thank you.
Okay, we can now examine the question, Dr. Mahmoud.
Dr. Huda, what is the diagnosis and differential diagnosis?
Yes, my
for
top
this
differential
case?
diagnosis. Yes, my top differential diagnosis would be lung cancer because of his long history of smoking history and lung disease that he mentioned may be precipitated by chronic obstructive pulmonary disease. Second differential, it could be, and with the association of this muscle pain and rashes could be with associated polymyositis. The second differential could be infection, exacerbation of his chest condition. And then could be heart failure, acute heart failure. Yes.
Yes. So what is the positive finding in your case, either from the history or from the examination? What you found? Why?
Yes, regarding the history, he has a long history of cough that exacerbate recently. This cough associated with the phlegm that is maybe green sometimes in color, with associated difficulty in breathing with weight changes. Yes, regarding the examination, my positive finding was decrease in air entry in the right lower part of the lung, with dullness to percussion, with the bronchial breathing throughout his lung. There is no signs of pulmonary hypertension and no murmur. My other positive finding, he mentioned skin rash on his hand, and I don't know if he mean by that Cotrin.
What is the name? What is the name of this rash?
Could be Cotrin babule.
Yes,
and
Gutteron
he
Babule.
and
Yes.
he yes, and with the positive proximal myopathy.
Yes.
Yes, yes, this
He
is
has
fine.
lymph node, doctor, or no? He has lymph nodes or no?
Yes, I didn't check the lymph node of the patient.
What is the cause of this wasting of the muscles of the dorsum of the hand and the guttering?
The top differential would be cancer with associated polymyositis.
Okay, okay, doctor. What is the bedside test for this case?
Or dermato, yes. Okay.
Bedside test is
For dermatomyositis, you mean?
for cancer lung.
Bedside test.
What is the most what?
I didn't hear the questions clearly.
What is the bedside test for this cancer lung?
I don't have any idea. A bedside test.
Okay, okay. Thank you, doctor.
There's still one more and 30 seconds.
خلاص, enough.
You finish questions? Okay, I will ask you.
Okay,
I will
okay.
ask regarding the bedside test. What do you think you can do while the patient sitting in his bed? What bedside test you can offer? With the
Yes,
head.
okay. Spirometry, okay.
Yeah, so we need to look at respiratory wise. Any respiratory test you want to do, apart from the child, you have to know them in order. Spirometry, blood gas, right? You will do blood gas. ABG, yes.
Yes, blood gas
Okay.
analysis.
What image you want to do?
Imaging.
Yeah, what? In the form of what?
The voice is not clear.
Yeah, the imaging in the form of what? What image you
Yes,
want to do?
imaging could be chest X-ray, CT scan, and the
Perfect.
echo study.
Okay, what type of CT scan you want to do here?
Yes, pan CT scan.
Pan
High
or high
resolution.
resolution
Yes.
or CT cap, chest, abdomen, and pelvis? What do you
Yes.
think? Okay, regarding Horner syndrome, you mentioned ptosis, right? What do you know about Horner syndrome?
Yes. Horner, yes, can come with mainly with apical mass in the lung, causing ptosis with a dryness in the face.
So give me the triad: ptosis and
Ptosis, meiosis, and anhydrosis. Yes.
perfect. Okay, and what's this lesion called? The apical lesion in the lung. What's it called?
Pancreas tumor, yes.
Okay, perfect. Excellent. Okay, let's go to Dr. Muhammad. I know there was some difficulty in the history taking. There is some lagging. That's why we added a lot of minutes. But we will comment on that after Dr. Mahi comment, okay? Let's start with Dr. Mahi, please. Dr. Mahi, you can comment now?
No comment there. Enough what you did.
Okay. Do you think she missed anything? She tell about her performance. What she spent longer to take history and examine.
Yes, for the taking history, we should be targeted more than like this. And we should, as you teach us, hit every system quickly. I think she only catches the disease when I told her that I lose weight. At that time, she become go to the track of the cancer lung. But before, if I did not tell her from myself that I lose weight about 4 kilogram in last 4 months, she cannot catch the disease. So I found that the time is going about 8 minutes like this, and she's still not going to the track. So I from myself told her, doctor,
You correct him.
I lost the weight. And the heart doctor told me, she did not ask me about smoking. So I told her, heart doctor, tell me, stop smoking, please stop smoking for your heart, like this. So this station 5 or long clinical consultation, we should hit every system quickly,
Yes.
not coming to the headache, and what headache or is not headache for the body at all, like this. This case is full of positive clinical examination finding, but we cannot catch all because no time. يعني we reach about 13 minutes and not yet examine the patient. This patient has pleural effusion,
Yes.
limited chest dullness, pleural effusion. There is bronchial breathing on the lung. There is lymph nodes. There is Horner syndrome. There is wasting of the muscles of the hand, like this. There is dermatomyositis or polymyositis. So patient is full of positive finding for this.
Yes. I agree with you. She wastes a lot of time analyzing the complaint, which is short of breath or chest pain. Around 6 minutes, Dr. Huda, you're asking about,
Yes.
and he was, yeah, the history was confusing also because there is heart attack. You want to know about the heart attack, the medication, then you ask about surgery, then you ask about short of breath. So the best way, just give 3 minutes maximum for the complaint, then skip it. Otherwise, you'll be confused and you will not reach to anything. What happened in this scenario? You analyze it for 6 minutes. You are asking about how the chest pain, how the short of breath, while sitting, while standing, or how the position. It's not cardiac. He said one pillow. Skip it. Leave it totally. And he gave you a clue from the start. I wrote it in the chat box. He told you the phlegm now is smelly, right? So there is something different than the cardiac cause. It's not cardiac cause. Any change of the character of the phlegm means there is something serious ongoing. Either infection, serious infection. So the question for any contact with sick patient or TB patient, I agree for that. The question for, of course, constitutional symptoms, you must ask this question from the start because the character of the cough changed already. But you kept asking about the chest and the heart symptoms, which is not the case here at all. Even differential, you cannot say this is pulmonary edema or this is heart failure signs. Why? Because it's not frothy. There is change. There is also smelly cough and all phlegm. It's going with cancer. The fatigue. You analyze one complaint, which is the cough, but you didn't analyze the fatigue. It might be the clue for this case. If you started with the fatigue, it would be much better to reach to the diagnosis. You didn't analyze the fatigue at all. Maybe you remember it at the end. And Dr. Muhi helped you also. He gave you a clue when he said, I lost some weight. Then from this weight change and loss of appetite, you know the case. The smoking as well, you must ask by yourself. Don't let him explore it for you. I guess it was confusing when he had the heart attack and the chest pain. It make you more confused. But no worries, it will be much better with the time. Even the examination, you can do it in perfect way because of also of the lack of the time you didn't do the proper examination. For the ptosis, for the Horner syndrome, you didn't do it, right? You missed the examination of Horner syndrome. Uh, I guess the case now is clear for cancer, dermatomyositis due to smoking, of course. And the case was not clear from the start. I agree, it's a difficult scenario, but you should learn on this difficult level because whenever you did this level perfectly, any scenario you can do it clearly and properly. Okay, Dr. Huda, you have any question?
No,
You
thank
can
you.
comment now. You can comment. Yeah, I want to listen from you.
Yeah,
What do you think?
yes, what make me confused, yes, is mainly this his long history of ischemic heart
Yeah,
disease.
exactly.
So I will
Yes.
try to just exclude any possibilities of any infection or, but yeah,
Yeah.
as you say, it was more clear that when with the
No,
weight
it's
change.
not clear, by the way. It was vague.
Yes,
The
because
weight.
I know, because in the history, if I say he have a problem with his heart, I think he focused mainly. I have 2 years of
Yes.
heart problem.
Yeah.
Yeah, it's just if he mentioned just one time, I think would be more clear. But he insists in the history that he have this long history of 2 times PCI, and yes, this make me
Okay.
focus on cardiovascular.
One question for the heart to know if this is heart failure symptoms or not. You asked the pillow or
Yes,
the awaking at night, gasping for air. You already
yes,
rolled it out, but still you are
right.
thinking about it. What the medication and how
Because
do you
I
handle?
thought,
Yeah,
yes, because I thought this could be even an infective endocarditis with even a blood clot in his lung.
pulmonary
So
embolism. Yeah.
yes,
Okay.
and even infective endocarditis. I don't
Okay.
know. I thought
Remember.
it was
Yeah, no,
cardiovascular.
no, it's okay. By the way, I was also confused, not only you. But the way how to overcome this problem, if you ask the system review, if you are lost in the complaint and the analysis of the complaint, please skip it. Don't waste a long time in the analysis, more than 3 minutes.
Yes,
Maximum 3 minutes, it's fair enough. Onset course duration and skip it. Past medical history, already finished and it's diagnosed too long and it's controlled, skip it. Any surgery, skip it. Constitutional symptoms here, if you ask, as Dr. Mahir, if you hit the constitutional symptoms from the beginning, you might catch the case. He will tell you,
right.
yes, I lost weight, I lost appetite, I have some lumps or bumps, I have also night sweat, I have night body temperature or night fever. Anyway, we are
Yes,
learning from the mistakes, and believe me, all of us were confused and we missed the diagnosis. But when he mentioned the gastroenterobacterial, yeah, I know that this is dermatomyositis, okay, related to the smoking, and the smoking is the exaggerating factor for his lung mass or lung cancer. Clear?
clear. Yes, if I just cut the cardiovascular history initially with the weight question, and yes,
Don't
I
be
will
frustrated,
more
Dr.
early.
Huda. Don't be
Mm?
frustrated. Your exam is still right. I think you have long time for the exam. So don't
My
be like that.
my
I know
exam in
you're
April.
April.
Yeah,
You're Irish or basis UK?
yes, basis.
Basis. Okay, no worries. We will have a lot of opportunity to practice with us. No worries. Okay.
Okay.
I will give you priority now. From now ongoing, you will be the priority will be for you because I think no one closed exam like you. So you will be the prior for the exam for the practice. Okay.
Thank you. Okay.
Most welcome. Any question from you?
No, thank you.
Okay. Try to shorten the question again as advice and to hit the system review and to jump to the examination. If you didn't know the case from the history taking till the minute 8 or 9 maximum, run to the examination. Don't wait. Okay, this is another advice for your performance. Okay, Dr. Moha, you have any question or comment? Anyone has comment or question?
No, thank
Dr.
you, sir.
Dr.
Thank you.
Mohi, your scenario was written earlier, so you can
Yeah.
yeah, prepare yourself and I will receive some comments. Anyone has comment, want to help Dr. Huda, any positive comment? Okay, your scenario, 40 years old male present with hematuria. Let's make him Adam Smith or John Smith. Change the name, John Smith. Okay, John Smith, 40 years old, present with hematuria. Please, anyone has comment? Okay, I will try to read these comments quickly. Lambert Eaton, I guess Dr. Ahmed Said, you were writing Lambert Eaton, right? Yeah, I thought about it, but I guess it's not the case. Spirometry, ABG, yes. Sorry, was my voice, yes, because I was outside, but I fixed it. I'm in the car now, so I think it's more clear now, the sound, right? Also return to the information again to the surrogate. Yeah, I believe there was some lag in the internet from Dr. Mahi. And there is also big questions or big answers from Dr. Mahi's side. I agree for that. So also she was confused by these answers.
Why?
And
He said because no blood. It is not a must for any cancer lung to give cough blood. If it is peripheral cancer, not it is not away from the main bronchus. No blood come with cough.
no, it's
So
not only this. The issue of cardiac, the cardiac issue was also, I think, uh, more details from your
my
side.
answer was clear. All no evidence
Yeah,
of
but
hematuria,
you
no
told her
evidence
about
of
the BCI, the stents, and she was confused by this. Anyway,
yes.
suppose the surrogate will be in the exam, I mean, will be target in the answers. He will not make you confused, okay? Because they have clear cases. They are not giving tricky cases. Unless it is so clear and the examiner instructed the surrogate to be tricky or hiding something. But usually they are helping, not hiding, okay? So don't be upset, Dr. Huda. In the exam, they will be much better and they will be also more clear, and the time management will be much better than the online one.
Okay.
Type of coughing and sputum were guided toward chest, not heart. Yes, I agree. Sputum was clear, and I said once he mentioned in the first moment, I have cough and the phlegm changed in the smell. You have to think about chest. Nothing in the heart can make the phlegm smelly at all. Even heart failure, it will be frothy without any smell, right? So take care of every word from the surrogate. I guess Dr. Mohi was helping in this clue when he mentioned I have changed in my smell of the phlegm. It will guide you to something serious. And I wrote it earlier, but I wish you didn't also read it because I prefer not to read the chat box while practicing. Yeah, so Dr. Hajwa or Dr. Tagwa, wish you success. Hopefully, inshallah, Dr. Huda, you are doing perfect. And also, you are practicing a lot, which will give you more uh, hopeful, inshallah, to pass. What the link of heart attack in this case? The heart attack just, I think, to distract the doctor, the candidate. It wasn't the case. Just to highlight, Dr. Dalia, just to highlight, dermatomyositis rash is photosensitive, perfect, often, and worsened by sunlight. Okay, so this is a good comment. Thank you, Dr. Dalia, for correction. So, Dr. Mahi, the rash of dermatomyositis will be worsened with the sun exposure. Although it's not in the face, yeah, it's not in the face, but or you mean the heliotrope rash, Dr. Dalia? You mean yeah, the heliotrope. Okay, but the Guttrum papule is not rash. It's darkening. Yes, perfect. Okay, this case was long-standing COPD complicated by pancreas tumor and dermatomyositis. Yes, exactly. I think this is Dr. Mayada. One more point: the clubbing, Dr. Huda, don't miss the clubbing from the hand examination. Clubbing and tremors. With any chest case, examine the hand for clubbing, leconychia, colonychia, and tremors, fine and flapping. In this case, you might have clubbing because of the cancer.
Okay, and I think what was vague also in the history, I think that regarding, I asked about any medication in the past, he always mentioned Plavix, aspirin, and his long history of, I think,
Yeah,
COPD. Never
yes.
mention any inhaler or problem with his lung. Try just to direct me to the cardiovascular. I use aspirin.
Okay.
He say that he's
All
fine.
of us will guide you next time. Okay. Don't be, I feel like you are very frustrated. No worries. Still, you have time, and I will
Yes.
give you again the opportunity. Okay?
Okay.
And it happens with all of us, not only you. Not to catch diagnosis, it's okay. I prefer to have mistake here rather than in the exam. So just get the confidence of practicing here and be ready for your exam. Let's start, Dr. Mahi, if you're ready.
Okay, sir. Okay.
Yes, let's
It's
start. Here you go.
what is the name of the patient name?
Yeah, Miss.
John Smith.
Mr. John
Smith.
John Smith?
Yes.
Okay. Okay. Hello, good morning. I'm Dr. Ismail, Senior House Officer of the Kidney Department today. Am I talking to Mr. John Smith and you are 40 years of age?
Yes, doctor.
Nice to meet you, Mr. John.
Okay, doctor. Nice to meet you.
Today I will discuss with you related to your health and examine you and address your concern. Is that okay with you?
Yes, it's okay.
Can you tell me how I can help you today?
Yes, I came to know the reason for the changes in my water work.
Yes, what is the problem in your water work, Mr. John?
Yes, I've been noticing recently that I have this blood in my water work, and I came to know the reason for it.
This is the first time for you to pass blood in your water work?
Yes, this is the first time.
For how long? How many days now
I
or
noticed it.
months?
I noticed it recently, 1 day ago.
One week ago?
1 day ago.
1 day ago.
Yes.
Which specific time of the day you pass this blood?
No specific time. It's just I noticed it 2 episodes, and I came to know the reason for it.
When it is in the early morning or the evening?
Yes. No, it's no specific time. Not in the morning or the evening. No.
You notice this blood come at the early of the opening your urethra or at the end or mix it with the urine?
It's all over the stream of my water work.
All over the stream. Any pain associated?
No pain.
It is dark blood or fresh blood, red color?
Yes, it's a rough of fresh blood.
Fresh. Okay. Okay. And no pain? You told me no pain?
Yes, no pain.
Do you have any tummy pain?
No tummy pain.
Any pain in the flanks of your side of your tummy?
No.
Any change in your water work recently?
Yes, I have this blood in my water work, but no
Other than
change.
the,
No other complaint. No.
no change in the amount, either increase or decrease?
No.
Any frothy urine?
No.
Mm. Do you have any past history for the kidney? Do you have any kidney problem before?
Yes, I have a kidney problem. I've been on dialysis since 2 years.
You are on dialysis nowadays?
Yes, on regular session. I attend about 3 times a week to have dialysis session.
What is the cause of this kidney damage?
They didn't tell me any. I didn't know any reason for my kidney damage. I just know that I have kidney failure and does not work properly, and I should have this dialysis.
Before they shift you to this dialysis, what was your condition? Do you have any hypertension, raise of your blood pressure, any
No,
blood from your chest, any
no,
cough
no,
blood,
no,
any cough blood,
no.
no raise of blood pressure?
No, I suddenly I have decrease in my water work at that time and been feeling tired. And they say that I have kidney failure, and they start with the dialysis.
Okay, okay. Do you have any bleeding from any other orifice of your body?
No,
No bleeding in the skin?
no,
No pus of stone?
no.
Okay. Do you have any lung problem before?
Lung?
Any cough? Huh?
Lung problem? No.
Uh, do you have any cough? Any noisy chest?
No cough, no noisy chest, no.
Do you have any joint pain? Either now
Ye-
or before?
yes, I feel my joint pain all over my body. They told me because of
When-
the problem in my kidney that I have this regular joint pain and pain all over my body.
But before this dialysis, do you have any joint pain before?
No,
Any skin rash?
no.
Any change in your weight?
Yes, I've been having losing like about 2 kg of my weight in the last 2 months. Yes,
Any lumps or bumps in your body?
no lumps or bumps.
Any skin rash?
No skin rash, no,
Any rash on sun exposure?
no.
Uh, Mr. John, can you told me, do you have any past medical history I should be aware of other than this kidney damage and on dialysis?
No, doctor.
Any medication list?
Yes, I use iron and vitamin supplementation. Other than this, no.
Sorry, Mr. John, you told me you are on dialysis for how long now?
For 2 years.
How many?
For 2 years.
4 years?
2 years.
2
2
years.
years. Yes.
Yeah, 2 years. Mm. And before these 2 years, you were okay at all? No problem? No any past history?
No, doctor.
Mm. Okay. May I ask you, Mr. John, I'm sorry to ask you this private question. Do you have any recreational drugs
No,
before the 2 years?
no,
Any painkiller, any?
no.
Okay, okay. May I ask you, do you have any changes in your bowel habit?
No changing my bowel habit.
Any feeling sick?
Sorry.
Any feeling sick or throwing up?
Yes, I feel tired and sick. Yes.
This recently?
I feel tired all the time, but yes, recently I've been feeling more tired.
Recently? Yeah. Any difficulty swallowing?
No,
This tiredness you feel, it is at a specific time of the day or all the day?
all over the day, all the time.
Hmm?
It's all over the day and all the time.
Yes? This tiredness, where you feel this tiredness?
All over my body, doctor. My joints. I feel sick. All the time. Yes.
Mm. Mm. Do you have any
No.
I think there is disconnection from Dr. Muhi's side.
Mr. John?
Sorry, doctor.
Mr. John,
Yes.
I sorry to ask you, do you have any changes in the figure of your nose?
No.
Do you have any headache?
Yes. Slight headache, dull headache all over the day, but not that too much.
All
headache.
over the day. Okay. Do you feel dizzy when you're standing from sitting position?
Yes.
Anyone told you you are pale other than before?
Yes.
Any weakness?
No weakness, no.
Any abnormal sensation?
No.
Do you lose your conscious before?
No.
Any shaking of your body?
No shaking.
Mr. June, may I ask you, at these 2 episodes of passing blood with urine, do you have at that time pain in your tummy or your flanks?
No tummy, no tummy pain.
Any raise on your body temperature?
Yes.
Is this nowadays?
Yes, it's more recently. I think it's mainly with my problem with my water work. Yes.
Okay. Okay. Sorry, Mr. John, I will examine you and I ask you questions while I'm examining you, okay?
Okay.
First, I will see the hand for any abnormality. Do you feel a change in the color? Any become more pale? Any changes in the nail?
Yes.
Hmm?
No colinekia, no clubbing.
No tremors?
Sorry.
No tremors?
No tremor.
Pulse is okay?
And pulse is 100 regular.
100, yes. Okay, what about blood pressure? I wanted to examine blood pressure bilaterally in both upper limbs. It is okay. How much?
Yes, it's normal. 130, no postural drop.
100. Okay, 100. Okay. Any proximal myopathy?
Negative.
Okay. I will see the face for any abnormal changes, color or jaundice.
Yes, there is pallor. There is pallor.
What?
Pallor, but no
Pallor?
jaundice. Yes.
But no jaundice.
Yes.
For the mouth, I will check the mouth for any sores or any
Yes.
gingival hyperplasia or any. Okay.
Yes, negative. Oh.
Negative. Then I go down to the abdomen. I will examine the abdomen, superficial palpation and deep palpation, and development for the kidney,
Yes.
and auscultation for the renal airway. Is there any? Do you have any pain, Mr. John? Before I examine you,
Negative. No.
oh, examination. What it reveal? Anything? Any organomegaly?
Negative. No organomegaly.
Okay. I also expose the patient and see for any skin rash, any purpura.
No purpura. But where to see this skin rash mainly?
In the lower limb, back of the lower limb,
Yes,
noxious
negative.
line purpura, negative.
Negative.
Okay, okay. Sorry, I wanted to examine the upper limbs also for proximal myopathy and to see the cannula, site of the cannula. Mr. John, may I ask you how you do dialysis? Peritoneal dialysis or
Yes,
fistula
no,
or
through a fistula
huh?
in my right arm.
Through what?
A
Right
fistula
arm?
in my, yes.
So I will check this fistula and auscultate it for any murmur, any berui, any
Yes,
signs of
it's
infection.
functional. Yes, functional and recently used.
Recently used and no infection. Okay.
No
Okay.
signs of infection.
Okay. Esther.
2 minutes left.
Sorry, Mr. John. Okay. خلاص. Okay. What is your concern, Mr. John?
I want to know reason for my bloody urine.
So before I answer your concern, Mr. John, do you smoke?
No.
Do you drink alcohol?
No, doctor.
Okay. And you did not receive any blood thinning medication?
No.
Only during dialysis? They gave heparin during dialysis only, so?
Yes, only during dialysis.
Okay. And apart from this, do you pass urine regularly or your urine become very low amount after dialysis?
No, it's normal, doctor.
Okay. You and examine you. There is no clear cause for this other than infection. So possibly the urine pipe. I will take sample from this urine and I will do imaging for your kidney. Then I will update you with this, the release of this, after release of this investigation. Okay,
Okay.
Mr. Joe.
Okay.
ماشي يا هدى بتطلع عليا كل
Okay, well satisfied. Let's go to examiner question.
Okay, so can you present your finding?
This patient, 40 years old, male patient. He has end-stage renal failure on hemodialysis and through fistula in the right arm. He has pallor and looks anemic. He has fever and he lost weight only 1 kilogram in this last month. And he has 2 episodes of hematuria mixed with urine, stream of urine. He denies that urine amount decreased by the end-stage renal failure hemodialysis. So I'm thinking possibly he has infection in his urinary tract.
Okay, and what possible side of infection other than upper urinary tract in this case?
Maybe infection of the fistula itself, as the bloodstream and the bacteremia.
Okay,
And,
other side?
hmm?
Other side?
No side, no other side, because
Okay.
he deny anything.
Okay.
He deny.
Right. So if I told you that he have shortness or difficulty in breathing, and if you ask uh, to explore for any murmur in his heart, do you expect to see any finding?
I skip the examination of the chest and heart because there is nothing in the history indicating his troubles in this.
Okay, and
But least
okay.
likely to develop infective endocarditis in this case because he has no cardiac history before.
Cardiac?
No, because of the fistula. Yes, you mean right side heart, right side cardiac valve is because of the fistula.
Could be to fistula, could be associated to glomerulonephritis, hemorrhagic
Yes,
infective endocarditis.
yes, you are right.
Okay, so if you do investigation for this patient, what will you send?
I will take 3 samples, every sample 1 hour apart from different sites, aerobic and anaerobic, to check the typical organisms for infective endocarditis. This is most important. Then I will do echocardiography, and because this is right side mostly, so transesophageal echo will be the optimum to check for any vegetation in the right side. Then I will do echo also, ECG also to see the BR segment, if it is prolonged or not, to say if this infection is spread to the cardiac muscle itself. I also take sample from the urine to see if it is infection or it is glomerulonephritis, type of the castis. This is the red blood cell castis or no, specific for the glomerulonephritis.
Okay, that's all my question.
You're done with the questions?
Yes.
Okay. He mentioned the investigation, right? Full investigation.
He mentioned blood culture,
Okay.
ECG, echo study. Yes.
Any image?
Imaging,
image
echo study, ECG, could be chest X-ray. Yes.
Echo. He mentioned echo, right? How to manage this patient, Dr. Mo?
This patient need admission, really. He need admission, and I will do a multidisciplinary team, non-pharmacological and pharmacological. We will start empirical 2 types of antibiotics after taking the samples of blood culture. And then if the culture came typical organisms for the infective endocarditis, we will continue these antibiotics for 6 weeks because he has no cardiac valves before. So possibly 4 to 6 weeks. Under the size of the vegetation. If the vegetation is more than 2 centimeters, at that time, it is risky for the spreading and the emboli to the lung, causing septic emboli. If it is less than 2, so we will continue antibiotic only without surgical intervention.
Okay, you ask about the headache. Why you stress on the headache in this patient? What do you think?
I wanted to do systemic review as you teach us, but
Okay, if the
I did
patient
not
give
see
you,
what's really.
okay, I will. Okay, let's imagine a scenario with headache and a patient with family history. What do you suspect? Family history of headache and kidney issue. What do you think?
Yes, I wrote it here. The differential diagnosis of this young age and
Okay,
intestinal polycystic kidney disease with aneurysm of the
perfect. But you didn't
yes,
ask about
but
family history.
she did not ask about family history.
Your
Mm,
your sound is
family
breaking.
history
Did you ask about family
maybe.
history, Dr. Mohammed?
No,
I
I
guess no,
forget.
right?
صح يا دكتورة, I asked دكتورة هدى for family
Dr.
history or no?
Mohi?
Yes.
I think he has connection issue.
دكتورة هدى, I asked you
My question was about
about family
headache
history.
and family history of kidney problem or
He
renal
he
failure.
he asked it. He asked it
He asked
early
about
about family
family?
history. Yes,
Perfect. Okay.
any family history with renal problem.
Okay, perfect. Now the time for comments. Dr. Huda, you can start please your comment.
Yes, this is a scenario of a 40 years old male with a history of on renal dialysis. He complained of hematuria. So the analysis was a painless hematuria all over the stream. So the differential, it could be mainly glomerulonephritis disease, and that would be either IgA nephropathy or post-streptococcus glomerulonephritis, and could be excluded by asking the patient about any frothy urine or puffiness or recent flu-like illness in the last few weeks or days to exclude it. The other cause could be renal cell carcinoma, which could be presented with weight loss, lumps or bumps anywhere in the body. Could be Wegener's with associated vasculitis, and this could be excluded by any nasal problem, as he asked, or any changing in the shape of the nose, any eye pain or eye problem or joint pain. Other could be possible any blood thinning medication, or could be asking for any bleeding disease in the family to exclude hereditary hemorrhagic telangiectasia or any associated thrombophilia disease, right? And it can, the last differential, it could be infective endocarditis, because the risk factor for, the reason for infective endocarditis would be mainly because he's on renal dialysis. So one of the risk factor for infective endocarditis is hemodialysis, could be IV drug user, and he excluded throughout his history, could be associated with a prosthetic valve or rheumatic heart valve, or could be even a normal valve. So this is a case of hematuria or patient on dialysis. The reason, the top differential, it could be associated glomerulonephritis with the immunological phenomena. The other is the fistula in his hand, could be a source of infection. That's my comment.
Okay, I want to ask what the previous cause of his kidney failure?
I didn't say the previous cause. It could be even simple cause of glomerulonephritis, just to make the history not much complicated, right? So it could be any cause for his kidney failure. I didn't make the history just too long about the reason for
Yeah,
it.
you know, you let him ask a lot of questions just to know what the cause of his kidney failure. He wants to know
Yes,
only
and
that.
yes, and this is also distracting. But also, if I didn't specify any particular cause, just to let him focus more of the reason of hematuria in the history.
Okay, perfect. Dr. Muhi, well done, of course, because your yes, the question, yeah, you analyzed it well, and you reached to the diagnosis later on, but you were confused again by the cause of his kidney failure, but you didn't know why the patient is having hematuria right now, right?
So
I
you
think
say,
till the end.
Dr. Bassem, I before I go to the scenario, while I preparing for it, I wrote the differential diagnosis: vasculitis, cancer, polycystic kidney disease, glomerulonephritis, blood thinning medication, thrombotic thrombocytopenic berbera, Knox line berbera, good Pasteur syndrome. I wrote this all differential diagnosis, and I was planning for asking the target question for every of this, but I cannot. I confused in the middle and go away from that. It was
Yeah,
infective.
you put autosomal dominant polycystic kidney, right?
Yes, I put it third one after vasculitis and cancer.
Yeah, perfect. Okay. Blood thinner also, I prefer to ask it earlier. It will help you. History of infection also, it would help you to rule out either IgA or glomerulonephritis, both streptococcal glomerulonephritis, right? Put it in your mind always. Any hematuria in young patient, the three common causes of hematuria in young age, glomerulonephritis as post-streptococcal, and it will be preceded by 2 weeks. The second is IgA nephropathy, and it will be 2 days apart from the infection. So it will preceded by 2 days infection, upper respiratory tract infection, and the autosomal dominant polycystic kidney disease. Plus other cause like cancer or stone, uh, just UTI. It could be, but this is the most common in cases wise. Okay, post-streptococcal and IgA nephropathy and autosomal dominant polycystic kidney disease. Clear, Dr. Mahi, but you did it great. Although the system review was little bit disorganized, you couldn't do it in the system review wise from up downward. I guess you were confused why the patient is having kidney failure. That's why you spend a lot of time to ask about it. One more point also, always when you have positive thing, analyze it. So he has kidney failure and he told you I do dialysis. Ask him how in the exact time and in the first time he mentioned you. Ask him how you are doing this dialysis from AV fistula, from catheter. According to the history, you will know, and from this also could be the a clue for your case. Okay. I think apart from this, you did great. You asked about the tremors and you signs of uremia, the signs of hypervolemia. All this you have to analyze it in any kidney patient. Family history also is very important here to rule out autosomal dominant polycystic kidney disease. We can open the discussion. Anyone has comments? But before that, any question, Dr. Mohi? Any comments?
No, sir, thank you. But yes, without any cardiac history or structure abnormality,
Your sound
the
again
heart,
is
still
breaking.
Patient
Yes,
without
he
structural heart
has.
disease still has
Yes,
predisposition to
yes,
arthritis
because of
from
frequent,
IV line.
yeah,
IV line.
frequent needling. Yes.
Mm.
Also from the perm cath, if he has perm cath, it would be also a reason and the clue, and it will be the trigger for the infective endocarditis. Put it always in your mind. Infective endocarditis also as a cause of hematuria. And the good thing here, you ask also about the recreational drugs, which also was a good question. Any other
And the
question?
character of hematuria in glomerulonephritis is painless, mixed with
Painless?
blood urine.
Yeah, and all through the water wall.
Also,
Yes.
okay.
You can analyze in this way: onset, course, duration, then hematuria analysis. Is it bloody or dark urine? Does it change with the on air? Just to know what the nature of hematuria, what you mean by hematuria. Then, how do you think the blood? Is it all through or earlier in the stream or at the end? So from this question, you might know what is the source of the blood. As you know, glomerulonephritis will be continuous, urethra will be early in the stream, and the bladder will be late. Okay, with the stream, I
Okay,
mean.
sir.
Yeah.
Thank
Apart
you,
from
sir.
this, yes, the onset, as you ask, previous history of this hematuria is a good question, and I believe you did great when you ask any previous condition I should be aware of, and she told you, yes, I have dialysis, and in this time you can know there is some kidney issue in this patient. You can ask about also stone, passing gravels. All this will guide you to the renal stone, but it will be associated with renal colic or hematuria, which will be painful. But in this condition, it's painless one. Blood thinner medication supposed to ask this question in any scenario. You have blood in the urine or in the cough. You have to ask about blood thinner medication or in blood from any other area in the body. It's very important question. You ask also about GPA, which is common in the exam. GPA, how any change of the nose of the face. You ask all the causes, which is very good. You try to roll out the all possible differential in this scenario, and you did it in perfect way. So in general, you did the case well, Dr. Noor.
Okay, sir. Thank you.
Most welcome. Any question else, Dr. Huda? Any comment?
No,
Can you mention the differential again for this case, Dr. Bassem?
Yes, Dr. Huda mentioned the infective endocarditis in the top. Glomerulonephritis, of course, glomerulonephritis, complicated infective endocarditis. Or she said also IgA nephropathy as a preceded infection. I don't know if there was history of preceded infection in this scenario, Dr. Huda, or no. And she said also renal cell carcinoma as he have change of his weight or losing weight. Right, Dr. Huda? This is his hair differential.
yes, right.
But yeah, in the in your as a topic, I mean, topic wise, you can put any cause or any cause of differential for glomerulonephritis in this scenario. But in the top, you have to put infective endocarditis. What's your suggestion, Dr. Aisha? What do you want to add?
Just I suggest about the fever. This is the fever can point toward also cystitis or
Yes,
to be
UTI, yes,
infection
could
more,
be.
to be infection, like yes, infective endocarditis, cytomegalovirus. This thing is also I think common with dialysis patient.
Yes, but with cystitis, I think the stream of urine would be more clue. That is initially in the stream.
And
There
it
is
would
pain
be
also.
painful.
There will be
Yeah,
pain.
exactly.
Yeah.
Yes, yes, exactly.
About asking about the cause of renal dialysis, try not to, if they hide something, not to go more with.
No, no, you have.
Like in my cases, my case in exam lung consultation was he has cabbage surgery, I think. And when I asked him past history, he is in heart failure and anemia, severe anemia like this. I asked, he has any operation before? She said yes, she has heart surgery. I asked about what type of heart surgery. She just tell me that I am not sure, I don't know. And I'm not going more because okay, she will not
Okay.
say about, so they will not let you point to this. When you examine, you will see the heart card, you'll see
Okay.
there is, yes, a lot of things. Just Yes,
I will
they want
clarify.
you something. They want you from you to point, and this for time. If the case will be complicated, they will not hide some points not to be the case more complicated or for the time, or they didn't tell the surrogate about this information, so he don't know really.
I will answer you in this point, Dr. Aisha. But what do you think if you miss the history taking about the way of doing renal replacement therapy? Okay.
Yes,
He
you
was
should
about,
ask, but
yeah.
if they hide, okay, don't ask
No.
more.
By the way, they will not hide. This is important because this is a case of hematuria. And there is RRT, renal
Even my case
replacement
was
therapy.
heart failure, doctor, as passing, and I asked what is cardiac surgery. They said I'm not sure, I don't know. And she is severely anemic, 6 outside. So I asked because if he is on blood thinner or something, they said I'm not sure, I don't know. They don't know what's the cardiac surgery, and this is strange,
Okay.
right? Really.
Yes, you're right. But if you miss the history and you didn't ask it and you miss the examination, you might lose the whole mark from the clinical communication and from the examination. But if you at least you ask and the time not allowed you to do the examination, you can get the mark and you will know that you are looking for the cause and for the good symptoms and for the signs what the patient is having. I think Dr. Mohi was about to miss this in the examination, except when he asked about what the way you are doing dialysis.
I think
I
here
think at
also
the end.
it's vital to see the fistula and
Perfect.
yes,
Yes.
to
And
any
this is the
infection in the
yes,
fistula,
this is
because
the
it's
trigger.
also common of fever. Yes. Hmm.
Exactly, yes. Any other comments? Well, good comment, Dr. Aisha.
The other case, the first case, because I have no chance to comment, in any cough, COPD, any change in cough, they learn us like that. Any change in cough, it is cancer until proven otherwise. So if from the start, Dr. Huda, he said, change of cough, you will put cancer in first differential and you will search for it.
Yes, but I didn't know that he have even a COPD. I know that he have
He
a
has cough for years and it changes for months. It's very common presentation of cancer in COPD patients or any bronchitis case.
No, he said something like suppurative lung disease. This color.
He said, I
this
have
color is
cough for
fatal.
many years and it changes for the last months.
That signifies suppurative lung disease rather than cancer. Especially he denied this hematemesis.
Maybe
Or
it's
hemoptysis,
COPD
sorry.
also, but he has low weight loss and he has change in cough, and you should put this, it is cancer firstly.
Rather than suppurative lung disease, lung abscess, bronchiectasis, this should be top the first. Come on
Bronchitis
the top.
come with years, not with months. No bronchitis in months, even. No. It will
No,
be
I'm not
for
talking
years.
about duration. I'm talking about this. He mentions this sputum changing, no blood.
Yeah. Yes, if bronchitis, it is for years. To have bronchitis with profound sputum, it is for years. Maybe he has not bronchitis and also complicated.
Okay, you can say lung cancer, lung abscess, ما في مشكلة. If there is, it is acute, could be lung abscess rather than lung cancer.
Lung abscess will have fever and night sweating. And I think not perfusing sputum like that. Because
it will
cavity.
be localized. Yeah, it will be localized. It will not be diffuse symptoms.
And it can be also differential, but you will put the dangerous differential in the first, as we learn.
Yeah.
That you need to exclude.
Yeah, the most serious and the most differential that you need to admit the patient for. Especially you have here signs of neurological involvement of sympathetic change, which is Horner syndrome. Okay, thank you, Dr. Aisha. Welcome. Any other question? Any comments? I will read the comment. Dr. Dalia, if you want to add any comment, please. I read your comment, but you put a figure. Yeah. This is the Gotrin, right? Gotrin Papure for the mad
Just hi everyone. just to highlight about the rash of dermatomyositis. It's like sunburn. It's not only if you see these knuckles, not only confined to the knuckles. If he exposed to sunlight, all the skin, it's like erythroderma or sunburn, and it's really severe. You can say that someone is like burning his face, his neck, and if you remember the shower sign, the everything, it's to sun exposure, and not only the heliotrope rash, the whole face will be covered with the skin rash, or red, or hands, back, every area. If you see one, it's really, really, really something like someone is burned. Okay. So,
Perfect.
okay,
So it's not
just
not
if you,
only
not
heliotropes.
only,
Yeah,
yeah, not
Okay, we
only
got
for
it now.
that. And if there is if the patient said is sensitive to sun exposure, don't just do this is SLE alone. Okay,
SLA,
this is a message that I want to let people know.
Okay, perfect.
Okay.
Okay, this is for the first scenario. For the second scenario, any comment?
I'm sorry, I got a phone, so I didn't
No
hear
problem.
the.
Okay,
Okay, thanks.
no problem. Thank you, Dr. Dalia, for
Thanks.
the
Thanks.
clarification. And thank you for the photo. Anyone want to see this? This is the Gottring field. I will
This
save
is,
it and
yeah, it's not only Gotron, it's extend for
even
all the palm. Yes,
okay,
the Gotron is just opposite to the knuckles
knuckle.
of the
Yeah,
hand.
yeah.
Okay.
Okay. Thank you, Dr. Dalia.
Where is this photo? I cannot see.
I will share it. It's in the chat box. I will share it again to the WhatsApp group. Dr. Huda, not all COPD patients take medication. Some are in mild symptoms only. This is Dr. Hatil comment, and can tolerate it without drugs. I agree. So don't expect to find drug history related to each diagnosis comes in your mind. Exactly. Okay, we commented already about the first scenario. Dr. Rashid, by now, for how long on dialysis? Yes, of course, we have to know similar condition in the family. Okay. So he is cardiologist, so he is in his, yes, I guess so. That's why he knows the vegetation size and too much details about infectious endocarditis. Sorry, I didn't hear what disease with headache. Yeah, autosomal dominant polycystic kidney disease with very aneurysm. You have to be ready for this. There is a scenario in cases, either communication or long clinical related to autosomal dominant polycystic kidney disease with a headache. So you might have subarachnoid hemorrhage with autosomal dominant polycystic kidney disease as perianeurysm rupture. So be ready either in the communication, they might raise this point or concern, or in the clinical communication, you might have patient presented with subarachnoid hemorrhage, and if you analyze more, you will have headache. If you analyze more, you will have autosomal polycystic kidney disease in the family, like patient on dialysis, his father on dialysis. Okay. Yes, already Dr. Zainab Lashin explained autosomal dominant polycystic disease with intracranial arterial malformation, very aneurysm, exactly. History of trauma is important, and in pain and in 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 pain and bleeding like hematuria. Yes, any blood from any orifice. You can ask this question, just rule out any trauma. It will not be the case because they will not bring for you a case with hematuria due to urethral trauma or urethral injury. It would be another thing medical. Okay. But you have to ask it just to rule it out and to show the examiner that you screen about the trauma. Dr. Rashid, if the case was acute kidney injury, I think the hematuria will be strongly related and significant. Yes, I agree. Perfect. Nice session, Dr. Huda and Dr. Mohi. Any question or comment from others? Any comment, any question? So I would end the session if no one having comment. I would like to thank Dr. Mohi and Dr. Huda. Again, I encourage Dr. Huda to have more opportunity if it's
Thank
suitable for you to practice.
you. Okay.
I
Thank
can
you.
put your name for the whole sessions, and who want to practice with you will be the
Yes,
one changed. But for
yes.
you, according to your situation also, if it's okay for you.
Yes,
Just
it's
let
okay.
me know.
Yes.
Okay. Okay. Thank you again for practicing today with Dr. Muhi, the clinical day. Thank you, everyone. Dr. Aisha, Dr. Dalia, everyone. I don't want to miss any. Dr. Rashid, Dr. Hatem, Dr. Zaina. See you tomorrow, inshallah, with communication day. Good luck and good night. Assalamu alaikum wa rahmatullahi wa barakatuh.